Hello, everyone. Welcome to this journal club organized by the ERA. And we've selected a very nice paper called Transient Acute Kidney Injury after Chimeric Antigen Receptor T-cell Therapy in Patients with Hematological Malignancies. And it's our great pleasure to welcome our author, first author of the paper, Juan León-Román from Barcelona, Spain. He's working in the nephrology department at Vall-d'Hebron University Hospital, Vall-d'Hebron Institute of Research, National Unit of Expertise for Complex Glomerular Diseases of Spain in Barcelona, Spain. And it's also our pleasure to welcome the all-female panelists, all from the US, Dr. Shruti Gupta, who is actually working at the Brigham and Women's Hospital in Boston, Massachusetts, Dr. Sandra Herrmann from the Mayo Clinic, Rochester, Minnesota in the US, and Dr. Rimda Wanchoo from Hofstra Northwell School of Medicine in New York. It's my pleasure to co-host this with my co-moderator, Amaryllis van Craenenbroeck from Leuven, Belgium. And with this, I would like to hand over to Juan León-Román to present the data.
So thank you for the presentation. I'm really happy to be here in this meeting, and we're going to start the seminar about CAR T-cell therapy and acute kidney injury. These are my disclosures. So adaptive cell transfer is a term that was first coined to describe the infusion of lymphocytes to mediate rejection of organ allografts and to treat tumors. So from the 90s, first generation CARs started to be constructed and evaluated as treatment of hematologic malignancies. CARs are engineered synthetic receptors that function to redirect lymphocytes to recognize and eliminate cells expressing a specific target antigen. CARs consist of four main components. The first one is the extracellular target antigen binding domain, which is the portion of the CAR that confers target antigen specificity. The second one is the hinge region, that is the extracellular region that provides flexibility and contributes to the length to access the target epitope. The third one is the transmembrane domain that stabilizes the CAR expression. And finally, one or more intracellular signaling domains, which are associated with one co-stimulatory domain in order to enhance response. So the patient journey for the CAR T-cell therapy starts when the T cells are collected via pheresis from the patient. T cells are re-engineered to produce chimeric antigen receptors on their surface. The number of the patient genetically modified T cells is expanded by growing cells in the laboratory until there are many millions of them. These CAR T cells are frozen and they are sent to the center where the patient is being treated. One of the major aspects that we need to take into account is the short-term toxicity that is include the cytokine release syndrome and also the immune effector cell-associated neurotoxicity syndrome. The first one, also called CRS, is caused by the CAR expansion and the massive release of cytokines. The onset is 1 to 3 days after the infusion, and features include fever, hypotension, and hypoxia. Second, the ICANS, the cause is the impair of the brain-blood barrier integrity, secondary to the high ratio of cytokine levels between cerebrospinal fluid and blood. And also there is evidence about the presence of CAR T cells in cerebrospinal fluid. The onset usually is 1 week after the infusion, later than the CRS, and features include aphasia, confusion, seizures. The common risk variables are the disease burden, peak CAR T cells and cytokine levels, and for ICANS, early and severe CRS. Also, we need to take into account the long-term toxicity that is include hypogammaglobulinemia, prolonged cytopenias, late bacterial and viral infections, delayed neurologic and psychiatric events, and subsequent malignancies that usually start 1 month after the infusion. So CAR T cell infusion can lead to cytokine release syndrome, secondary to interleukin-6 release along with other inflammatory cytokines. Acute kidney injury results from a combination of hypoperfusion, secondary to a third spacing of fluids, hypotension, cytokine-induced cardiomyopathy, and direct inflammatory effects. So this is a complication that hematologists and nephrologists must be aware. Kanduri, in her meta-analysis published in 2021, described the incidence of acute kidney injury among patients treated with CAR T-cell therapy and was among the 18.6%, and the pool estimated incidence of severe acute kidney injury or acute kidney injury requiring renal replacement therapy was about 4.4%. Therefore, the incidence of acute kidney injury among patients with CAR T-cell therapies varies from 5 to 33%. The mechanism of acute kidney injury after infusion is not completely understood. But resuming the information available, we can say that the incidence of acute kidney injury is low, the severity of injury is mild, and most patients recover kidney function within 30 days. Also, a complete renal recovery by day 30 after acute kidney injury was seen in almost 70% in non-renal impairment patients. But what about chronic kidney disease and CAR T-cell therapy? Also, the general principles are that baseline renal impairment is not associated with a higher propensity of acute kidney injury, and a complete renal recovery by day 30 after acute kidney injury was seen in 71% of renal impairment patients. Also, many authors agree that hyponatremia, hypokalemia, and hypophosphatemia are common adverse complications. And hyponatremia is due to the excessive release of interleukin-6 and the overexpression of vasopressin. Hypokalemia, secondary to the release of cortisol or renal tubular defect, and hypophosphatemia is related to the release of interleukin-6 and also the overexpression of fibroblastic growth factor 23 and phosphaturia. So I have problems with this. Okay. So we can get a conclusion with this information that is already being published, that CAR T-cell therapy was highly effective in patients with renal failure, both with and without persistent kidney disease. With this information, we decide to conduct, the study Transient Acute Kidney Injury after chimeric antigen receptor T-cell therapy in patients with hematologic malignancies. Sorry, the presentation don't work. This is a retrospective study to identify risk factors for acute kidney injury and long-term outcomes after acute kidney injury in patients who receive CAR T-cell therapy. We review medical records of 115 patients treated with CD19 target CAR T cells between July 2018 and May 2021 in a 30-day period. So 24 patients developed acute kidney injury and 91 patients did not. In the group of acute kidney injury, 18 patients were diagnosed with new onset of acute kidney injury and 6 patients were diagnosed with acute kidney injury over CKD. The first table shows the demographic characteristics of the full patient population. Briefly, the median age was 61 years old. Most of the patients were males. Hypertension was present in 37%, diabetes in almost 8%, chronic kidney disease in almost 10%, and dose-reduced fludarabine in 12%. The most used CAR T-cell construct was a T-cell with almost 50%. The table 2 shows the clinical outcomes after CAR T-cell infusion in the 115 patients. First, the ICANS any grade was present in 33 patients. ICANS grade more than equal than 3 in 4 patients. CRS any grade in 95 patients, and CRS grade more than or equal to in 35 patients. 34 patients required steroid therapy and 37 tocilizumab. 6 patients were admitted to the ICU and 36 patients died. 31 due to the disease progression and 5 with a non-progression related mortality. In the last group, 1 patient died secondary to a congestive heart failure, and the rest secondary to a bacterial septic shock. The next feature shows the prevalence distribution of patients with acute kidney injury in the first 30 days after the CAR T-cell infusion. As you can see, 2 patients develop acute kidney injury in the preconditioning chemotherapy with fludarabine and cyclophosphamide. And by day 1 after the infusion, 3 patients develop acute kidney injury. By day 7, 13 patients. By day 14, 1 patient. By day 21, 2 patients. And by day 28, 3 patients. In terms of acute kidney stage, we use the Akin score, and 17 patients develop acute kidney injury stage 1, 4 patients stage 2, and 3 patients stage 3. Of these 3 patients, 2 require renal replacement therapy. Unfortunately, 1 of these patients died secondary to CRS grade 4 and refractory septic shock, and the last patient survived with recovery of kidney function after 1 month. Fortunately, in our cohort, there were no cases of severe electrolyte disorders, but we can see that by day 7, I cannot see, let's see, yes, by day 7, hyponatremia, hypophosphatemia, and hypocalcemia were the most frequent side effects of changing electrolytes disorders. And by day 21, hypopotassiemia and hypomagnesemia were also frequent. When we perform the vibrate analysis, male sex, chronic kidney disease patients, hypertension, CRS more than or equal to, and ICANS more than or equal to 3, and that were associated with acute kidney injury development. But only male sex CKD patients, CRS more than or equal to, and ICANS more than or equal to 3 were independently associated as independent risk factors after multivariable analysis. Also, CRS, ICAN, hemoglobin, and creatinine show no statistically significant impact on mortality after 1 year of follow-up. And in terms of survival, we performed the survival analysis stratified by acute kidney injury development, and there were no differences between these 2 groups in terms of progression-free survival and overall survival. Similarly, results when we stratified the analysis by chronic kidney disease, that we did not see differences between the groups in terms of progression-free survival and overall survival. So as conclusions, in our study, 21% of patients develop acute kidney injury, usually in the first week after CAR T-cell infusion. Most of the patients recover kidney function within the first month post-treatment, suggesting that acute kidney injury is frequent but mild with a fast recovery in this setting. and males and CKD patients, CRS grade more than or equal to and ICANS grade more than or equal 3 were identified as independent risk factors for acute kidney injury development. And the name of the nephrology service of the Belgium General Hospital, I really appreciate your attention and thank you so much for this opportunity.
Thank you very much, Juan. I think it's time for some questions now. I don't know whether there are questions in the chat. I don't see any. So maybe we can start with one of our distinguished panelists. Sandra, you might have some questions.
Yes, just some comments. I think it's nice to see that the study of Dr. León-Román corroborates the previous studies that have been published, that AKI is most common to occur in the first week, so we have to pay attention in those patients, especially during the first week, and be really attentive to signs of either CRS or ICANS, that it can be sometimes very subtle, and have this multidisciplinary team that act upon the treatment, as he has shown that some factors like CRS of the higher degree, and also medications that they require more, tocilizumab or some corticosteroids might be associated to that. So those patients should be really treated by the protocol, which, most centers have this well determined, and it can help to look and give a better care of those patients. I know he has described some of the factors, like especially ICANS of seizures, things, but those can be very subtle, as they just ask the patient to write on a piece of paper. If they start, writing in this organized way, they already can find those signs. I think it was a great study, the largest looking at AKI in these patients. I just would like to see and ask it to Dr. León-Román. In our previous studies, we look at like tumor lysis factors that would be related to the AKI. If you had the opportunity to look at this in your study.
No, we don't have, but right now we are reviewing the data also to include this, because this is another inflammatory response that could affect, we could enhance the inflammatory status of the patient, and also could produce the acute kidney injury. So we are right now reviewing the data, because this is also important. Yes.
Yeah, because I think we really have to pay attention. Those are the patients who require more extra care, even though, as you've shown, the AKI can occur, usually it's mild and transient. I think if you're on the top of that, we may be able to even improve those outcomes. It's a great work.
Also in the hospital right now, there is more, the protocols are better, so they are paying more attention in order to diagnose this complication earlier. And also the blood samples or the blood test include these parameters in order to stratify these complications. And also this is going to help us in future studies to associate the risk factors or mortality and then.
Yeah, I agree. We need more. I think we need to put this together, because then we can have, when we did this, there's some signal that CRS, but we could not prove that because of the outcomes. Because, there were not many patients, but with the systematic review, we can really see, and it makes sense those patients have inflammatory system, ramped up, that to be more at risk. But I don't know what my other colleagues, Dr. Gupta and Wanchoo, think about that.
Sorry, Sandra, can you repeat what you just said?
Yeah, I think as Dr. León-Román was discussing, that we have to be paying attention to some more details. Like in our study, we have availability to, really follow the group here at Mayo. They have this protocol where they follow the tumor lysis, labs, LDH, and think, and really we can, and really at minimal increase or change, they can opt on and treat the CRS or ICANS symptoms too. That makes the AKI less common because they're very upon, as I said, there's some things when I was rotating with the CAR-T team that I didn't know. They asked the patients to write on a piece of paper their name, and as they not follow the line, they're already, oh, this is already a CNS involvement, so they already treated. So I think that the more people doing this, we can get more information, see how to act upon those signs early on.
Absolutely. Yeah, no, I agree. I agree. I think, I think this is a big study. It has, shown us some additional information, but there's still so much that we don't know and that we can perhaps, learn. And hopefully there'll be bigger studies, more patients. I actually had a couple of questions. First of all, Dr. León-Román, that was an excellent presentation and a great paper, so congratulations. The two questions I had was, one, I know you had about, I think, 30 stem cell transplant patients that were in your study, right?
Sorry.
There were the stem cell transplant patients, you had about 30?
Yes, we had 25% of patients received the autologous hematopoietic cell transplant, and only one patient received allogenic, yes.
Yeah, so did you see if there was a difference in the risk of AKI amongst patients who got stem cell versus not? I just curious.
We didn't, but we have the data.
We have the data.
Yes,
yeah, I just wonder, because these patients have evidence of endothelial injury, then you expose them to CAR-T, there's more cytokine release. Maybe their risk for AKI is a little bit higher than somebody who hasn't received. So that was one. The other question I had was, there's been some literature on how the type of the CAR-T can be associated with higher risk of AKI. So I think, so did you see that? I think that wasn't Dr. Gupta can probably comment also. She was on that study where I think they thought with AXI capitogene, they found a higher risk versus the other type. Did you look at that?
Also, no, we didn't look that, but this is another thing that we can add as an information, because it's valuable, and also because it's in the hospital, they use 4 types of CARs, so we can perform this analysis. It's going to be a short analysis, but with a lot of information, yes, we can perform that. And one thing also that Dr. Herrmann is that we already talked to the hematologist, because we really need to get urine samples. So when these patients enter to at the hospital to receive the treatment, or before and after, with the blood test samples, right now they added a urine sample always. Not a 24-hour urine sample, but a spontaneous, yes.
If I just have a short comment from the audience on that. So there is a first question: have other findings than ATN been reported in biopsies? Which makes also allusion, of course, on the underlying mechanisms of kidney disease. And I guess with the urine sample, you want to see proteinuria or not, or sediment changes. So the first question would be, do you have any biopsy data? And second, if yes, is there other mechanisms or other pathophysiologic topics seen in those biopsies?
Yeah, unfortunately not. We don't have the kidney biopsy. But I think that this is one of the most important things, because if we can perform a kidney biopsy, we can know what is happening in the renal tissue, but unfortunately we don't have.
Yeah, and there was also another question, which was an anticipated question for this journal club. Would the group recommend a kidney biopsy in dialysis-dependent AKI after CAR T-cell therapy with neurological complications?
In a dialysis, I hear?
Yes, and a dialysis-dependent AKI. That's the question, apparently. Yeah.
Well, I guess, well, like a kidney biopsy.
Mm-hmm.
I think for the AKI, they were not ESRD and they developed and they didn't recover. Would you biopsy these patients? I think that's what they're asking to you.
Well, I think that in this moment, if there is a patient with end-stage kidney disease and hemodialysis, and there is not, or the kidneys are small, I think that this is going to be difficult to have a kidney biopsy.
Yeah, but I think for the AKI ones, what we run problems here, fortunately, we didn't have much of the issue. Those who developed this, they were really sick. And the main issue was they are very thrombocytopenic. They have some, coagulation problems. That's what prevented. There was, I believe, one report of some postmortem, but, look at this patient, but it's really hard to do at the time. When they develop severe AKI, at least the case that you had, that unfortunately some more now with other multiple myeloma things like that, they had hemophagocytosis syndrome. They were on CRT, but it's really hard to biopsy these patients because of the bleeding risks.
Also, the patients in this, I think in your case, in your study, there were 2 patients who required dialysis, but their creatinines were actually not that high. Was it primarily for volume?
Yes, it was for volume because these 2 patients require a ICU admission and were anuric for more than 12 hours. So respiratory distress was important, and we started continuous renal replacement therapy.
Yeah, so that's what
one of these patients was really sick, and the patient died, unfortunately, but the other patient recovered kidney function. To date is alive.
Dr. León, can you tell me, how did you define kidney recovery?
Well, kidney recovery was a little bit difficult, but we established that kidney recovery, depending on the baseline creatinine of each patient.
So like they had to sort of return to within 25 or 50% or something along those lines?
Yes, exactly. So this was individualized in every each patient.
Okay. Yeah, I mean, it's one of the challenges with all of these studies and AKI studies in general, OncoNF studies, right? Like everybody uses different definitions for AKI itself, severity of AKI, recovery from AKI. So I think we probably all need to kind of move towards a little bit more sort of uniformity with that. The other thing I'll comment on is, it's awesome. We have all of these sort of different single center studies that have found very similar findings, but I think it's challenging sometimes to really study risk factors, when you have relatively smaller sample sizes. And so, I think something like this also lends itself well to maybe a multi-center study, because again, the numbers of patients that had AKI and CKD, when you look at the survival curves, it's really hard to sort of make concrete extrapolations about, these patients' course when you're looking at 6 patients with CKD or 10 patients with CKD. So I think that's another thing we probably need to start moving towards, is larger studies where we can look at risk factors and outcomes, with regards to CKD in the long term. And then the other thing I'll mention, even with our own study, I think having control groups is really important. I think these patients with cancer, they have lymphomas, they're very, very sick in general. And so for us to say that these patients X% develop CKD without actually having adequate control groups, I think that's something else that we need to sort of think about in the future is, okay, well, if this proportion of patients develop CKD, well, what about a control group of patients with lymphoma who are equally sick? What happens to them? Is it equivalent? Because, can we really say that CAR T leads to CKD if we don't actually compare them to an adequate control group? So I think that's a really important point that, even with our own study, we didn't have a good control group in our AJKD study. So, I think things that we can all strive towards.
There's also, if we can work together, we can grow the blood, the sample, and also we can find, yes, the control group. That's because this is really important. It's going to define if a CAR T cell is a risk factor for acute kidney injury or not. Yeah.
Very good point. And I also think we have to work together for defining the AKI recovery and put them in guidelines, as the senior author of this article suggested in the chat. She's following. I have another two pragmatic questions for you from the chat. It's about prevention. So in general, what could nephrologists do to prevent the CAR T cell related acute kidney injury, as we expect it to be a therapy in the near future, for example, for lupus? What's your take on that? What should we do to prevent it?
Well, right now, hematologists only give crystalloids to the patients previously the treatment, but I think that they don't use any kind of medication to prevent the kidney disease. The only thing is to be aware if one of these clinical signs or symptoms started in the patient, in order to act rapidly and to prevent the progression of the inflammatory status. Because once we got the CRS or the ICANS, if the interleukin-6 is high, so we can start steroids, tocilizumab, in order to try to reduce the inflammatory status. But before that, I think that right now here in the hospital, we don't use any kind of prophylactic medication or other treatment.
And what about the patients with CKD? Again, a question of Maria Soler. Do you think that the patients with CKD deserve special attention in terms of prevention?
I think that they need more, we need to pay more attention in these patients. But the treatment is the same. So if one patient with CKD is admitted to receive CAR T cell therapy, I think that hematologists must inform to nephrologists that they expect a patient with CKD to receive CAR T cell therapy. So we can work together in order to try to prevent the disease or the acute kidney injury over the CKD.
I have a few points, if allow me. I think the difference talking about treatment for other gens like lupus from the cancer. From the cancer, you have the tumor burden. That's a really big risk factor that with the lymphodepletion therapy, that's what the hematologists try to prevent. But some patients will be more difficult than others. My impression with the gen, since the patients are not, being treated by tumors, I wonder if you won't see as many and have to be worried as much. Obviously, there is some idiosyncratic reactions they might have CAR T, and if it's really worth it to use for this type of treatment, as we have so many monoclonal treatments that can be as good as well and not as expensive. But I think just the fact to compare, treatment of CAR T for gen and tumor related, I think that's the only comment.
Okay. Is there some other comments or questions?
I have actually one. So what were the characteristics of these patients who develop AKI during preconditioning, which is pretty uncommon, I think.
Yeah, well, these patients, the problem was that these two patients received 4 and 5 previous chemotherapy without any kind of remission. So I think that these patients were very sick before the start the CAR T cell therapy, and also before the preconditioned chemotherapy. So they were more vulnerable in that period of time. But also CAR T cell therapy here was used as a rescue weapon. So in these patients that were really bad, really sick, they tried to reach remission, whatever it takes. So I think that this precondition status of these patients helped to enhance the acute kidney injury.
And I just have a simple comment. I really like the comment by Dr. Gupta, who mentioned that we need to define renal recovery in these patients. And it's also, in my field of research, immune-mediated kidney diseases, it's pretty much the same. How do you define, a good response or AKI recovery? And what are your principal remission criteria, basically from a kidney perspective? So I think this would be something very nicely if we can work together in different fields to actually achieve this, and also try to implement that for future clinical trials, because I think this is really relevant to our patient population.
Yeah, and along those same lines, like what is a baseline creatinine? Is it preconditioning, pre-cancer, pre-CAR T?
Yeah,
That's really important too.
Yes. Also, here at Battleground Hospital, we have patients from other cities. So we have only the creatinine before the preconditioning chemotherapy, but not the creatinine if the patient received previous chemotherapy lines in the past. So that is another thing, yes.
Okay, so I think with this constructive note on collaboration, I think we can end this journal club, and I can announce the next, which will be held the 30th of May. It will be Ulrike Lundström and Marie Evans presenting on the clinical impact of the kidney failure risk equation for vascular access planning.